So, Dr. Adeto, for the 40 minutes. The presentation is expected to take 40 minutes, while the question and answer session is also expected to last for 15 to 20 minutes. So as a rule of the webinar, we are expecting presentation until when it arrives. You don't type your question in the chat box, or you may raise your hand for permission to be allowed to speak. So I want to invite Dr. Adeto. For Adeto. Dr. Adeto. Hello?
Hello, sir. Can you hear me?
Yes, Dr. Adeto.
Okay, thank you, sir. I hope you can also see my slide. Okay.
Yes.
Okay, thank you. Good evening, distinguished teachers, colleagues, and resident doctors and all other professionals joining us on this webinar. Within the next 40 minutes, I will just be leading the discussion on trends in pain management, the usual and the unusual. I will be a bit fast because of the time constraint, because you all agree with me that it is difficult to discuss pain management in 40 minutes. But I will try emphasizing the important things that will be relevant to our practice and may be important to our passing exams as well, and relevant to our own sub-region. So I'll follow this table of content. In Latin, punishment or penalty is the meaning of the word says it is. We must believe the patient. Even if he's smiling and he's saying the pain is very much, it's a severe one, we must believe. And this is the most common reason why patients come to the hospital to seek doctor's attention. In 1979, according to the IASP by Mesky, it was defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Well, most of us are also aware that in 2020, there was a review of that to reflect certain category of patients or individuals that could not actually describe their pain. So pain has been recently defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage to cover animals and those who could not express themselves. We can classify pain broadly into acute pain. Those are of recent onset and are limited in duration. As soon as there is healing of the provoking injury, the pain should end. And that's usually less than 3 months, or some authorities will say 6 months. This is usually sudden. You can trace the cause of the pain, and there's a relationship between the cause and the end of the pain. But when you talk about chronic pain, which is the other type, it commonly persists beyond 3 months, or some authorities will say beyond 6 months. And you may not be able to trace the cause, and even after healing, the fellow may still be in pain. But these two could also be in a continuum. That's why you have acute on chronic pain or chronic on acute pain. There's another type called the psychogenic pain. This terminology is no longer commonly used, but it's important to explaining some of our constructs, in the sense that in this case, there are factors that are associated with some other illnesses which could perpetuate pain or cause pain, like in mental health and some other issues. It's been established at about 54.3% to about 72.5%. It is the incidence of pain, despite our knowledge, the technology around us, and the manpower we have, even whether we have a shortage or not. Patients still have significant pain even after surgery, whether day case or our regular surgical adventures. What are the challenges in Nigeria so that we can focus our mind? Most of the places still use intermittent intramuscular injections. Drug availability is problematic, especially opioid, which is the mainstay of the treatment of acute pain. Surgical team, rather than the anesthetists, are still the prescribers. So whatever be their own sentiments, still reflects. We have a lot of training as per pain management in the anesthesia world. But those who are really prescribing most of the time are non-anesthetists. And most of the time, there's no post-operative monitoring of pain, whether it is relieved adequately or not. Pain theories now, we have the specificity theory, which says the specificity theory refers to the presence of dedicated pathways for each somatosensory modality. And we have the intensity theory of pain. The theory defines pain as not as a unique sensory experience, but rather as an emotion that occurs when a stimulus is stronger than usual. That is, if you don't get to a certain threshold, there may not be that perception of pain. Pattern theory of pain states that any somaesthetic sensation occurs by a specific and particular pattern. And because there are neurons firing, and they fire at a particular rate and following a particular pattern, depending on what they code for, depending on the stimuli type they code for. Gate theory of pain, most of us are used to that because this suggests that there's a gate in the substantial generalization of the dorsal arm, and that transmission could be modulated around this area. When you stimulate the larger nerves, they tend to shut the gate, and when you stimulate the smaller nerves, those that are smaller in diameter, they tend to increase the transmission through that pathway. I brought this up to remind us of the pain pathway from the primary neurons, going to opening of ion channels, influx of and generation of axon potential, and then conduction of such. Then that will go to the dorsal on the spinal cord, and then excitatory neurotransmitters will have flow through the spinothalamic tract, even to the thalamus, and crossing the other parts of the brain to the cerebrum, where this will be interpreted, and the body can then know that there's pain. If you look at this picture also, it's pointing us to the fact that there are a lot of things that modulate pain: our experience, our expectation, level of anxiety, neurochemical and structural changes in the body, our genetics. There are certain parts that, they don't just believe in pain, and they may not express it as well. Sensitization, this is just talking about the fact that at certain points, because of certain things, especially because of the NMDA receptors, if they are upgraded, they could cause a winding up. That is, the body, the neural tissues become more sensitive to stimulus, and this could make patient present with higher levels of pain. And we have the descending pathway as well from the periaqueductal gray areas where you have the enkephalin, endorphins, some endogenous opioids that will actually help us control pain. And down the line that we will emphasize them the more. This is also expanding on that. We won't be talking too much about this because of our time. There are things that we already know. This one is showing us the areas of different activities of what we want to talk about. At the level of the brain, you could have the opioid acting there. The TCAs also act at that level. The spinothalamic tract, ascending, descending path. You can have the local anesthetic as we have in spinal anesthesia, epidural. Even in some cases, we have the TCAs and the reuptake inhibitors like tramadol and amitriptyline and so on, NSAIDs, that could work at the level of the dorsal horn cells. Local anesthetic also works at lower levels and so on. We'll talk more about this as we go. The descending pathway, like I said, we have the endogenous opioid pathway, suppressing the pain, serotonergic pathways, dopaminergic pathways, noradrenergic pathways. What are the effects of untreated pain? That brings to fore the importance of what we are talking about today. It could cause anxiety, fear, fatigue, sleep disturbance in this patient. It could cause depression, pulmonary dysfunction, which will lead to hypoxia because the patient does not want to breathe well, especially when this the incision site is closer to the diaphragm, around the abdomen. Patient does not want to breathe well, he doesn't want to cough. And that will reduce the vital capacity, functional residual capacity, and this could lead to a VQ mismatch. Stimulation of the sympathetic neuron because of the outpouring of so much of glucocorticoid, of so much of our catecholamines, you know, it could cause tachycardia. That will eventually increase the stroke volume, increase the oxygen demand of the heart, increase the work of the heart, and that could lead to myocardial ischemia. Because the patient does not want to move that part of the body, it's also a challenge. And that way, it will be encouraging thrombosis, which will lead to embolism as well, because stasis is the third portion of the virtuous triad. Ileus in the abdomen, vomiting, nonceptive because of some nonceptive impulse, hypomotility of urethra, which will lead to retention, sodium and water retention because of outpouring of the glucocorticoids, increased blood glucose free. You can also trace this to the glucocorticoid outpouring. Immunologic impairment, wherever you have so much of glucose, you agree with me that there will be depression of the immune system, and that will lead to poor healing, delayed prolonged hospital stay, and so on and so forth. Before we can treat pain, we must be able to assess it. And before we can assess pain, we should take good history. We must find out the location of that pain. A patient will not be complaining of pain in the upper limb, and you'll be thinking of giving an epidural. That will not be appropriate. The intensity of the pain will determine to what extent are we going. Simple paracetamol could do, or we may need to do a nerve block. Sensory quality of the pain may give it out, whether it's acute in nature or chronic. Alleviating and aggravating factor may also help us to decide how to manage this pain. Any new onset of pain requires a new comprehensive pain assessment. If you are treating a particular type of pain, and suddenly the patient starts complaining of a new type of pain, you must reassess, going through this series again. What are the tools that can be used? We have the numerical rating scale in adult. I'll show a picture of that to guide our understanding. Visual analog scale is there, defense and veteran pain rating scale. All these ones that are listed there, they are commonly used in adult, depending on which one is convenient for us and the amount of time we have on our hands to do this. In the pediatric age group, we have the neonatal pain agitation sedation scale, the neonatal infant pain scale. But in our own environment, we usually use the face leg activation cry and consolability scale and revised plaque, and then the Wombaker's faces scale around here, because this one is multi-dimensional in the sense that it takes into consideration more than one item, and that makes it a bit more objective. Like I said earlier on, pain is subjective. So what a patient A causes pain may not be pain to patient B, and the intensity may also vary in them, even with the same level of stimulus. So there's maybe a behavioral scale that is fit for 2 months to 7 years old, those that cannot express themselves appropriately. If you look at this table, those written in black are for the regular flat scale, but those written in red are the modifications that are reflected in the revised flat scale. And we score from 0 to 2. The total, because we have 5 of the items, will amount to 10. And we can grade them mild, moderate, severe, according to the score like we use for the regular scale. This is what it will look like, and we can score in those areas and then add up. Look at the verbal pain intensity scale. That would be no pain up to worst possible pain. We also have the visual analog scale. That does not bear the numbers, and that's why it is more relevant to a larger scope of patient, whether you have the knowledge of numbers or not. These can be used. But on the other side of the paper is written the numbers, so that whosoever is assessing can correspond it to the numbering, like we have in the numeric pain scale. But you agree with me that whosoever does not understand number may not be able to use this. But in the case of the Wombaker scale, like I said earlier on, is most often administered to children. This is not a situation where you are going to look at the faces represented there from no aught worst ever. But what we are rather going to do is to ask the patient to look at it and then do choose which one is relevant to the way the patient feels, and that makes life easier for us. So the patient is the one to look at these faces, we explain to the patient, and the patient will choose. So that means there's a level of cognition the patient will have before he can use this. So the pain interview is also this. I will not be expatiating on it, but we can see our PQRST pneumonia, we won't be able to do that. Defense, the events and veteran scale is also by the US Army several years back to assess the Army because they understand their trade, but they may not be able to follow our usual mild moderate severe. So this was used for them so that they could at least fit into one of these that is shown, whether it's a facial scale or no pain, hard to notice pain, and so on and so forth. These are means of assessing. We've also talked about this. Let's move on. This is the okay. I hope my tail is still okay. That's okay. So we go on. This is the comfort pain scale as well. We can use this as appropriate. Let me move on. This is the McGill's pain questionnaire. It's enormous and difficult to fill. If you have the time, it's also a good one. It's more objective than all those pain scores pain scales where you use just one element to assess. So pain assessment is often important. Even if you have assessed pain with any of these instruments or a combination of them to get the best, you need to reassess following administration of pain medications, whether there's a need. That administer a drug intravenously after 15 minutes, you should actually reevaluate your patient. But if you had administered oral, IM, or subcut, wait for about an hour because it will take such time for you to have the significant effect of your drug. Well, if you don't do this, you may be overdosing the patient inadvertently. So assume pain is present is a term used to document pain in patients who cannot self-report. For example, a patient who has severe head injury, the patient cannot tell you I'm in pain, but the same pain also sustained long fractures, maybe femoral fracture, tibial fracture. You should assume on behalf of the pain that the patient is in pain and treat the pain as appropriate. Pain management approach should be interdisciplinary and multimodal. That is what the trend is. That is what is preached. And most of us know this. But what do we mean by interdisciplinary? That is, so many people will be involved. The physiotherapists, the anesthetists, the surgeon will have something to do. Even if it's an I&D, if somebody is harboring an abscess cavity and you don't drain it and you keep giving morphine, you may not get any effect. Multimodal in the sense that we are going to use drugs which use different mechanism of action. Some men say local anesthetic that will have to cross the membrane and block the sodium channel from within, opioid that will bind to the opioid receptors, and so on and so forth. This way, we are going to reduce the amount of each drug to be used, and that way we avert the likely side effects of each drug. And in addition, they will also have synergistic effect rather than additive effect. That is, their total effect will be much more than the addition of their individual effect. So care is individualized. We must look for the pain source and intensity. The patient's age will influence some of these things, like I will mention later on. For a neonate, it will be different from what you do in a child. It will be different from what you do in an elderly patient because they are same way. It will be different from what you do in the pregnant woman. So developmental and physiological, physical and emotional cognitive status will also influence the cultural belief, treatment preferences, and concurrent medical illnesses. Somebody who has severe hypertension, you won't want to do neuraxial block in such a person as a form of treating pain. And treatment preferences, even if you have your suppository, you want to use it, but the parents are saying, no, don't use it on my child. That stops you. Multimodal analgesia, we've described this pharmacologic relaxation technique, regional anesthesia. We want to combine so many of them. Like it's shown in this picture, so at different levels, we have different things that we can do. And those are the levels at which we intervene, and this will aid our understanding of what exactly we are doing with those drugs. What are our treatment goals? We want to minimize or eliminate patients' discomfort and the adverse effect of postoperative pain, like I described earlier on, which will facilitate, if we can do this, it will facilitate early discharge from the hospital. Facilities, if I want to facilitate recovery process, avoid or effectively manage side effects of treatment if it occurs, then we want to be cost effective in all we do. What are the methods? Non-pharmacologic methods we include heat and cold compress, relaxation techniques, distraction, whether with music or with audiovisuals, guided imagery, acupuncture, acupressure, repositioning, acupuncture, acupressure is one of the new trends now, though not very new. That's why we rather said it is the usual and the unusual rather than say old and new. But people are improving on this to ensure that we stay away from the effect of opioid and some of the social problems with opioid, which is the mainstay of treatment of acute pain. Pharmacology method will include NSAIDs, anti-seizure medications. So I want to emphasize that not everyone that you see with anti-seizure medication is an epileptic patient. Antidepressant, not everyone with antidepressant drug is depressed. They are adjuncts to what we do. We can add them to our NSAID and even our morphine and the likes to achieve the best. Local anesthetic, then neurolytics. Neurolytics, in this case, will be injecting certain things that can damage the nerve. And this may be an endpoint because that nerve may never regenerate. So acute and chronic, let's quickly split it out. NSAID would be good for acute anti-seizure medication, antidepressant, opioid, analgesic, local anesthetic, neurolytics. Whereas in chronic pain, as we will see when I highlight the features, most of them will need anti-seizure medication, antidepressant, some NSAID, implantable devices, psychological therapy, because most of them are depressed. They've been carrying the pain for so long and they've not found a way out. Acupuncture, acupressure. Opioid may be an important drug if all these will not help. So requirement for effective treatment, we need knowledge that we are imparting or sharing knowledge now. The skill, with your intervention will be limited by your skill, experience of staff. When you are exposed, you know the pros and cons of each job. Proactive planning is also very important. For example, if you want to do an epidural to control postoperative pain in patient who wants to have laparotomy, it is not when the GA is already administered and the abdomen is opened. You now remember that you want to do an epidural. That would be too terrible. It will be too late. So we must be proactive. So we edit and inject an antibiotics through your epidural port. If you don't educate them, that might happen, and that patient will be paralyzed for life. Attentiveness to individual patient response is important. Drug availability will modify what you do. So regular pain assessment is important. Subjective pain reports is important. Pain relief, side effect of therapy, all this must be monitored in any patient we are managing. Standardized institutional, goals and designs is also helpful with this type of pain. Acute pain service is important, and chronic pain clinic will also help to ensure things. So let's go to management of acute pain. We have the low tech, but very high impact because it will cover like 80% of patients. 80% of our patients with pain, with acute pain, will benefit from this, and we may not need to go beyond that. So it reduces anxiety. Non-opioid analgesics are very important in this NSAID, are the best. You see in their case procedures, they are very oral opioid analgesic, also there oral morphine, fentanyl lollipops, and such agents. Wound infiltration is one thing we can do so easy. Referral opioid injection to the knees, and to some other joints will also help. Intermittent bolus opioid injection, subcutaneous IM intravenously will also help. And we also have what we call patient controlled analgesic devices, both those that are electrically controlled and those that are pressure controlled, that you don't need electricity for. High tech will include epidural analgesia. In this case, you need a high level of skill. Patient controlled analgesia, that, like I said, regional analgesic techniques, depending on your expertise. There's an entity called preemptive analgesia in acute pain management. It assumes that before incision is made, if you can administer your good dose of analgesic, you'll be reducing the ability of that patient to react to pain. Ultimately, that means you'll be able to catch up with the pain control better than when you are giving it after pain has been instituted and the patient is already reacting to pain, by whichever means. So, these are new modalities of drug administration that may be important to us. We have oral transmucosal fentanyl citrate, sublingual spray of oxycodone hydrochloride. We have subcutaneous ketamine now. We've been talking about ketamine for some time, despite the side effects of the psychotomimetic effect it has. subcutaneous ketamine could do a lot of work. Intranasal spray of fentanyl and all other drugs listed there. Topical ketamine is available now, lidocaine. Microspheres, these are things that have been made into very small that can percolate through our skin or through some mucous membrane of diclofenac and some other NSAIDs. You have celecoxib and the likes that have been compounded now, making life very easy. Pulmonary morphine that people can inhale fentanyl, transdermal autophoretic fentanyl, of the WHO analgesic ladder. So it was designed to manage cancer pain, in which case you go from mild pain, management of mild pain, to moderate pain, to severe pain. When you are dealing with mild pain as assessed by whatever instrument you are using, you are free to use non-opioid plus or minus the adjuvants like antidepressant, anticonvulsant, like we mentioned earlier on. And even non-opioid, like and you assess the pain to be more mild, the drugs meant for mild and are just mild treatment, mild pain treatment. You can move on to the moderate. You now have mild opioids like trazodone, plus or minus adjuvant, and so on. Then at the peak of it is by morphine. You know, some other drugs are stronger than morphine, then you can combine them with non-opioids and the adjuvant. Let's say analgesic, almost like the WHO analgesic ladder is almost relating to like when we talk about cancer pain, most of the time before cancer starts giving pain, it should have turned to a chronic pain, except you now have an acute on chronic with them. But this one tends to be more applicable to management of acute pain, like postoperative pain and such that are acute. So we start with strong opioids, injection, local anesthetic, and the likes. And when the pain is going down in intensity, we then go down to mild opioids, then we go down to NSAIDs. Let's go on to chronic pain. Chronic pain could be nociceptive or neuropathic. We have examples of neuropathic like central pain syndrome, in which case like stroke, in which case the patient had developed a stroke and because of the damage to the brain and some other neurons, is now having pain in several parts of the body. Complex regional pain syndrome is another one. Because of damage to a nerve, a particular region of the body could start presenting with all sorts of pain, redness, swelling, and so on. Diabetic peripheral neuropathy, we know that those who are diabetic and were not properly controlled develop neuropathy and start complaining of all sorts of pains that could be changing in character and even cause some ulceration after some time. Trigeminal neuralgia, this happens through the cause of the trigeminal nerve. There could be swelling, there could be peppery sensation, and it could affect any part, the eye, the nose. Patient could complain of any pain around that area. These are forms postoperative neuralgia is another one. So this table is showing us the different categories because of our time. Phantom limb pain, these are crossover areas. And if we look at them in this way, it will be easier for us to be able to manage them. But we must know that in neuropathic pain, what we are dealing with is a damage to a nerve, which is causing a lot of problems. Other forms are arthritic pain, back pain, low back pain is even very common now. Neck pain, cancer pain, you know, headaches, including migraines, could be very chronic. Testicular torsion, orchidia, you know, could affect muscle pain from fibromyalgia. In this case, you have some target, I've forgotten the right word now, but there are some points that if you inject during the treatment, if you just stick your needle there and inject a steroid, even just needling, just solve the problem. That's the origin of the problem. And neurogenic pain also come up from damage to nerves. How common is chronic pain? Is about 25% of the population, but the challenge is that most of them would have agreed that low is their portion, is their lot. Migraine could run in some families. Obesity could worsen pains of the joints because the joints, especially the back joints of the back, sacroiliac joints, the knee joints, hip, they all bear the weight of the body. Other people are likely, age will contribute, other people are likely to contribute. pain of arthritis, problem. Labor-intensive job, people carry heavy loads, who lift heavy loads, also have problems. Stress has also been associated with post-traumatic stress syndrome, also present with pain. Smoking is another challenge with these people. Characteristics of chronic pain could be aching, burning, shooting, squeezing, stiffness, stinging, throbbing, and in some of them, this character could be changing. The nature of the pain could be changing. Today is shooting, tomorrow is squeezing, next tomorrow is stiffening. So, what are the conditions associated with chronic pain? You have anxiety. So many of them could go into depression, and that's why we must look out for all this and treat them. If not, we may not be doing well and we may not be getting results. Fatigue, feeling overly tired, insomnia is another thing. They may not be sleeping well, and that's why the blood pressure is on the high side. It may not be a primary hypertension. Mood swing will occur in these patients. We must take all this into, that's why we need the multimodal, multidisciplinary approach to management of this kind of pain. How do we diagnose? We must ask the pain, the patient where the pain is, how intense it is. Let them score it from 0 to 10. How often it occurs, how much of it is affecting the life of that patient. What makes it worse or better? That will guide us. What is the effect of stress and anxiety? Whether the patient has had one illness or the other, or surgery that is related to such, also be sought from the patient. That guides us. There are investigations that could be done. Blood tests could reveal certain things. Electromyography will also reflect the effect of the pain on the muscles. Imaging techniques such as X-ray, MRI, CT will reveal the source of this problem. Especially when you go to interventional pain management, we do a lot of MRIs to be able to identify what we are dealing with and at the different level of the joint and know how to intervene. Nerve conduction studies could also give it up, because you see some patients from trauma, they could have nerve damage, and that could be what is presenting with so much pain. Reflex balance test, spinal fluid test, give it up in some conditions like multiple myeloma, and the urine test as well.
10 minutes to go.
Hello?
10 minutes.
We'll round off in a moment.
10 minutes to go.
Chronic management depends on the type of pain, the cause of pain, age, and the overall health of the patient. Medication is the mainstay. Lifestyle changes, we preach it to them. And some psychological therapies and physical therapies could also come in. So we seem to combine all this in management of chronic pain. Anticonvulsants are there, antidepressants, like we said, corticosteroids will help. Even muscle relaxant like ofenadine will help, because some of them will go into spasm because of the pain. Non-steroidal anti-inflammatory drug, several examples that we know, starting from acetaminophen to ketorolax and all the likes, will come into play here. Topical products like all sorts, including local anesthetics. The medical marijuana is to so that people and addiction, whichever way, is still part of what is used to treat. And we don't talk about addiction when a patient is actually in pain. Illicit. When the pain is over and is still stuck to it, then we talk about addiction. Other modalities could include transcutaneous electrical nerve stimulation. Nerve block could be very important, either as diagnostic or therapy, which will also lead to neurolysis. Epidural steroid injections, whether interlaminar or transforaminal under CM guidance, will be very important. And under X-ray guidance, you could do ganglia block in the head and so many other things for trigeminal neuralgia and so many other ones. Epidural pumps are also coming up now. You could plant the pump under the skin of the patient and then track the catheter surgically into the epidural space and then program it. So it keeps delivering the drug continuously. When it's exhausted, the patient comes back for a refill. Lifestyle changes could increase reduction of stress, tolerable exercise, that the patient diet, then sleep. Reducing stress is even applicable to us as anesthetists. We must reduce our stress, and that helps the fellow to think differently about the pain and know what to do. Counseling, Occupational therapy, the fellow may need to change the kind of job so as to lessen the stress. Physical therapy is also important from the physiotherapy. Alternative therapy could include acupuncture, which is, I think some of us in Nigeria could do that, but maybe we are limited by the equipment that will be used. Aromatherapy from plants and essential oil. Biofeedback, hypnotherapy, mindful training is another thing like yoga, and music has been found useful. Healing touch or Reiki is another important thing. Relaxation technique, meditation and guided imagery have been used successfully, but these ones have not given consistent outcome. Complications of chronic pain could include decreased quality of life, depression, anxiety, substance abuse, because they will now start buying drugs on their own in addition to whatever you are giving. They just want the pain relieved. Worsening of the existing chronic disease, an increased risk of suicidal ideation or even suicide will occur. Pain relief in special group, I will quickly say this before we round up. In pediatric age group, we must know that these people are not small adults. They have their peculiar physiology, anatomy. We must take this into consideration. The way they tolerate local anesthetic is less than that of adults. Their volume of distribution is quite low for some of our drugs, and we must watch out for some depression, respiratory depression, and the like. Calculate their dosages based on their weight per kilogram body weight. Elderly patients, their organ systems are not as functional as when they were young, so they can't handle these drugs very well. They have slow circulation as well. So when you inject a drug, you must wait for a reasonable length of time before trying to relate to them like you relate to younger adults, you may be overdosing them. In ambulatory surgery, we also have to take it into consideration that the patient must go home that same day. So we use short-acting drugs that will be very potent. We tend to use more of infiltration, regional blocks with diluted drug so that they can go home. They won't have the challenges, no urinary retention and the likes, and they can still go that same day. What are the novel issues from what I've stated now? Neurostimulation is relatively novel, recent, and it's doing a lot of things, especially in people who have pain, neuropathic pain, maybe from spinal cord injury and the likes. It is tracked through a mechanism as if we are doing an epidural catheter passage, but special needle that came in the pack. Then you pass that stimulator and track it under the skin, join it to the generator under their skin, and it could be stimulating them at a particular low frequency to reduce pain stimulations. Then stem cell transplantation, it's been found that those who have joint pain and the likes, their own stem cell could be harvested and then reinjected back to them. It's been found that this is also, but they are still at experimental stages. Medical marijuana, like I told you, is ongoing. It's been approved in some countries, but not in our country. That will not be a good reason why an anesthetic should be found with marijuana for now. Alternative therapies, like we said, is also very important. In this case, like our acupuncture, acupressure, aromatherapy and the likes, they're also novel. And there are things that we should try in addition to our usual, so that at the end of the day, we'll be able to deliver to our patient. Thank you for listening to this short discussion. I hope I've been able to meet your expectations, and I'll be waiting to take a few questions. Thank you, sir. Over to you, Dr. Galadima.
Thank you very much, Dr. Adetoye, for beating the time. I must commend you for that. So now the floor is open for questions, comments. But during the last 40 minutes, we were able to listen to Dr. Adetoye, where he thought of the pain, the trends in pain management, the usual and the unusual, right from the definition, the types of pain, the mechanisms, effects, assessments, the modalities of treatment from the old and the advanced. So it was actually a very wonderful presentation. So we want to hear from the audience whether there's questions or comments. But right in the chat box now, I have an announcement. There is the NSA president on behalf of the Board of Trustees and the Executive Committee and the distinguished members of the NSA. Welcome everyone to this webinar. So also there's a reminder on NSA dues payment. So, and also a reminder on the 25th SSPN Annual Scientific Conference and General Meeting Oshun. So question from the audience. You can either raise your hand or type your question in the chat box. Yes. Hello?
I think, Dr. Galadima, while we are waiting for questions from the participants, let us use the opportunity to hear from very senior colleagues that are here. I'm sure they always have something to say so that we can save time. But once there is question, we can now recognize the participant who wants to ask some question. On the chat box, I cannot see any question for now, apart from the announcement that we make. For example, I know we have the past president of the Society for the Study of Pain in Nigeria, who also happened to be one of the mentors of the presenter, Professor Paula Paponle. She's busy, but we want to allow her to say something for now.
Yes.
And we also have Professor Ilori, the faculty chair, anesthesia with African College of Surgeons. Please, Professor Paponle, let's allow her to say something while we wait for anyone who has a question. Thank you, Dr. Galadima. Professor Papolema, if you are still on, if you want to say something.
Hello?
Professor Papole. Is she still on?
Is she still on board?
Yes.
Okay.
Maybe she's not, she has to unmute. Prof, check that you have unmuted.
Front of Professor Ilori.
Okay, if she's not on yet, maybe she's having a problem if the Professor Ilori want to say something now.
Okay.
Hopma.
Hello.
Yes, ma'am.
I want to thank Dr. here for that brilliant presentation.
Thank you, ma'am.
Only that you had a limited time, so you were just racing. I think it was a little bit difficult for people to follow what you were saying. Actually, though the topic says the usual and unusual, I didn't really hear anything about the unusual. It was the usual. I heard something. Whether the time I went out to do, I left to go and do other things, whether you talk about the unusual. So what is the unusual now? Pain management.
What we mean by the unusual, there's nothing new per se. But what we mean by the unusual, is the fact that some of these things we don't do them in the environment here. That's why I technically avoided the word old and new. Because whatever we are saying now, maybe it will be new in our own environment, but it's not new to them in some other parts. Like the marijuana we talked about, like the nano drugs, like the microspheres, some of them are actually at preclinical stages. They may be relatively new. They are not in the market yet. Even the interventional pain management, how much of it do we do around us here? They are still relatively unusual to us in our own environment. I think most of what we do more in our environment is the use of the NSAID, where we have opioid. I think, thank God for our mentors and our leaders now. We are now having opioid more regularly in Nigeria now, unlike before. I'm sure some people don't need their training. They didn't even have it available, but now we are having it available. So we'll be talking about that. In fact, we are still limited in what we have. I'm sure we don't have fentanyl lollipops, the patches regularly, all those. So those ones will fall into the category of the unusual. But we also talked about the fact that there are acupuncture, acupressure, those things contribute a lot In fact, we also have to
Thank you.
bring it to our notice that look, aside our drugs, the therapies, cognitive therapies, physical therapy, all those, they also contribute a lot to pain management. Thank you, ma.
Okay, thank you. There's a question in the chat. There are some questions in the chat box, Dr. Adityo. So somebody was asking
Yes, sir.
if pain is what the patient said it is, then how do we manage those patients with opioid addiction?
Okay. Let me say this. When we are managing pain, there's a clear definition for addiction, though there is a crossover between addiction and dependence these days. We are talking about, when you are talking about addiction, dependence, you're already talking about a situation where a patient has gone beyond the issue of treatment. And now, even when the patient withdraws from that drug, is now having withdrawal symptoms, it's getting distressed by not taking that drug. And whatever is taking it for is already over. But what we are saying, what we mean by the fact that the patient should be taken for whatever he says is that you could go by the side of a patient and ask the patient, sir, 0 is no pain at all, 10 is worst pain ever. What will you score your pain presently? And the patient smiles at you and tells you, my pain is 9/10. You may doubt the patient. The patient may be doing it for several reasons. Maybe the relations are around and he doesn't want them to go into distress like him. So we must believe this patient and attend the patient appropriately, like whatever we get on our scale. And we've said it earlier on that it is subjective. So you may not be in a position to say, no, your pain should not be up to that. And the issue of addiction is a different ballgame entirely. We've identified that this patient, the pain is over. There's no more longer pain. And the patient is still craving for the drug. The patient wants the drug despite the fact that the drug is harming him. Then we now talk about dependence and addiction. Thank you, sir.
Okay, thank you very much. Then there's another question. They say, thank you, sir, for the excellent presentation. What is your take on the 4th step of the WHO ladder?
Okay, I intentionally stayed off that for because one thing that is still a bit controversial. The 4th stage is there. We now have an entity that is called the 4th step of the WHO analgesic ladder, which includes the nerve blocks, interventional pain practice when you do interlaminar, transforaminal, epidural injections, you do even discectomy, percutaneous discectomy and the like to relieve pain. If you get to level 3 and the pain is not still relieved and you can identify what exactly is the cause of the pain and you think you have what it takes to be able to go to that level, then it is acceptable. That would be my take. Thank you.
Okay, thank you. Dr. Ezekiel is hoping that this presentation will be uploaded on the YouTube. And then Dr. Okay, we have another question saying, what's the place of intravenous ketamine in the management of chronic pain?
Okay, ketamine has an analgesic effect because of its effects on the NMDA receptor is part of it. And with a low dose, sub-anesthetic dose of ketamine has been found to have an analgesic effect. So I also mentioned it that even the subcute, now we have it being compounded in some other forms, like with antiphoretic property and the like, so that I can go through the skin and so on and so forth. So ketamine has a role to play. Both, or you can use it orally, it can be intramuscular subcute, sub-anesthetic dose as an analgesic effect without really going into deep anesthesia.
Hello?
Hello, Dr. Galadima. Yes, sir. Can you hear me?
Another question. Yes, I'm hearing you.
Okay, sir.
The second question is that what's the place of trigger point injection in chronic pain management and patients that can benefit from it?
Yes, trigger pain injection, that's what I wanted to mention that skipped my mind the other time. It's very relevant in fibromyalgia. In that case, that trigger point is where the pain is generated from, and it then spreads to some other part. So if these points can be identified, even just needling without any injection will do the magic at times. And when you now need, you can identify that trigger point, stick in a needle, and then inject some steroid. It does a lot of work and it alleviates the pain of the patient. So it's relevant in fibromyalgia. Thank you, sir.
Thank you. Another question says that the WHO has a new bidirectional scale for the management of pain. Please, sir, can you throw more light on the scale for management of pain?
Okay, I said it earlier on that the WHO analgesic ladder was designed to manage cancer pain, but later adopted. But along the line, we now had the WFSA analgesic ladder, which is presenting itself as if it's just an opposite of that. So the WHO analgesic ladder tends to help with chronic pain management more than acute pain management. Because you agree with me that in cases of a post-operative pain, depending on the level of surgery that we did, the level of invasiveness of that surgery, we may actually need to start from opioid or the maximum level and then come down, which is typified in the WFSA analgesic ladder, going from strong opioid to mild opioid as the pain is reducing by assessment. But you won't ask, somebody will not be having a pain score of 9/10, and you can start with paracetamol. No. But like I said earlier on, that one was decided to manage cancer pain. And you agree with me that most often, cancer itself does not present with pain early. By the time you start having pain in cancer, most often, I'm not saying always, there's no never in medicine, the cancer is already spreading. It's either it's distending a capsule or it's crossing some boundaries. So in that case, we then can graduate depending on the level of assessment. Thank you, sir. Hello,
Okay,
sir,
thank
over
you.
to you.
The last question. Yes, what is the role of psychological therapy in management of chronic pain?
Okay,
The
so
role
the
of
role of psychological therapy, like I said,
Yeah,
the role of psychological
therapy.
therapy, like I said, is the fact that most people who have chronic pain and some who have acute pain actually develop psychological problems. Some of them, even some of the pain might be secondary to some mental health challenges. And either by physical violence to self or from some other events. And so some of them, especially most often, the chronic pain sufferers, they eventually have some level of depression and so on. So psychological therapy is very important for them. We do a CBT, we do some psychological assessment of them. What level, how does this affect their daily living? Somebody who has been relating well, who has been going out, who has been going to work, can no longer go to work because there's stiffness. Somebody who can walk miles, doing his work as an engineer, now has to sit every time, is concerned. So we need psychotherapy to take care of this. And in fact, the issue of pain, the definition of pain, are taking that into consideration ab initio by telling us that there's an emotional aspect to pain. Imagine somebody who had just been jilted and is saying, I'm in pains. Opioids will not solve that problem. It is counseling, it is CBT, it is psychological assessment and therapy. So it comes in handy when you have an emotional component to pain or when there's chronic pain or there's an acute on chronic pain. Thank you, sir.
Okay, thank you very much, Dr. Ajitoye, for all the questions and the responses. Yes, I want to hand over to the chairman of the Education Committee, and probably for our senior colleagues to say one or two things to the discussion. Thank you, sir. Dr. Lati.
Yes, thank you very much. I think there are a few short questions posted. The question will not end. Somebody is asking, can pain clinic go a long way in management of chronic pain?
Okay. And pain training?
Pain clinic.
Clinic, okay. Yes,
Yeah.
it's one of the things that can contribute to the management of chronic pain, because that affords the patient the opportunity to present, be assessed, and be reassessed. Because some of these people, for example, now, somebody who has surgery, and the surgery was over, the wound had healed, he's been discharged by his primary surgeon, and now is having pain back at home, maybe from nerve entrapment and the likes, the best thing would be to present to the pain clinic where he can be given drugs or an intervention, and he could be asked to come for a clinic visit where they can keep track of him. And then, so it contributes a lot, whether acute pain management team in the hospital or a chronic pain clinic. Both of them will contribute excellently to the treatment of pain. It helps us to identify those who are managing this pain. They can keep track of it. It's not everybody's affair now. It's now seeing somebody who is keeping track and seeing how the patient is doing on the drugs. If he's having complications, he withdraws some, adjust the drug, and so on and so forth. Thank you, sir.
Yeah, thank you very much. Like I said, the questions will not end, but Dr. Olateju is reminding us just to underscore the importance of this topic, pain management, that to register for the forthcoming Society of for the Study of Pain in Nigeria conference in Osun, that's Osun 2023 at Ile-Ife. So I'm sure many aspects of the pain will be discussed there. Thank you very much. Now, before I hand over to the president of the NSA, I want to recognize the presence of the president of the Society for Society of Specialists in Airway Management Nigeria, who just concluded a very impactful maiden conference yesterday. You're welcome, Dr. Adeshian. And I want to ask some of our colleagues in surgery. There is Dr. Oseni, a plastic surgeon in Aminu Kano Teaching Hospital, and also Dr. Davu Shah from surgeon, I believe, in University of Abuja Teaching Hospital, Gwagwalada, and also Dr. Aminu Abba, who is a hematologist in Aminu Kano Teaching Hospital, who they also run a sickle cell clinic. Can you just say something about whether you are able to benefit from some of the things being offered in your centers? Dr. Hosseini, maybe we'll start. Okay. Go ahead, please.
Hello, good afternoon or good evening, everyone. Thank you, Professor Detti, for introducing us, and then thank you very much, the presenter and the organizers of this wonderful and highly impactful lectures. I think for us from hematology perspective, dealing with sickle cell disease patients with acute pain crisis and some chronic pain syndromes like chronic leg ulcer, osteonecrosis, and avascular necrosis of femur and stuff like that. I just want to appreciate the Society of Nigerian Anesthesia for this organizing this, and it provides a forum where pain could be discussed and the importance of multidisciplinary care in management of pain. In sickle cell disease, for example, we we deal with a lot of issues to do with pain management, psychological issues, and then substance addiction. Sometimes it becomes difficult to balance, like somebody commented earlier, to balance the pain care with the risk of addiction. And then it becomes somehow difficult to even say at what point people tipped to addiction and dependence and sensitization and things like that. So mine is just to appreciate the need and probably bring to our notice that multidisciplinary approach to pain care is very important. For example, availability of opiates may just determine how you treat pain, even though you deal with pain that will require opiates. If it's not available at your disposal, or if the right opiate is not available, then you have to make use of what is available and which may be substandard, and that could cause tip patient to risk of seeking and craving for treatment. So mine is just to
Sorry, I couldn't hear the last statement. Dr. Amin Abba, thank you very much. I don't know if Dr. Oseni quickly, and also Dr. Dabusha, the orthopedic surgeon from Abuja. Dr. Oseni, if you are on, please. Because you are a plastic surgeon. Dr. Oseni. You have to unmute. Okay.
I'm not sure he's still on board. There is only a Dr. Hussein Damilola.
Yeah, he's the one. Maybe he's
Oh,
not.
I see. Okay.
Yeah. So, Madam President, I think you should let me allow you to make your remarks as usual. Thank you very much.
Okay. I must thank everyone for being available this evening to keep a time with us. Before I make my remarks, I think we should allow Professor Fola Fakonle to talk to us because she was the former president of SSPA and she has keen interest on pain management. And I would also want Dr. Chima Nnaji, he's the only one I can see here from diaspora. I think he should talk to us about his experience over there. Thank you.
Thank you very much, Madam President. It's been exciting for me staying on with this webinar this afternoon. I found out when I got here that we in Nigeria, we're far advanced in terms of our pain management principles and the techniques. All these trends that we're talking about here is not so well known. And part of the things that I find myself doing here is being an advocate for pain management, post-operative pain management, sickle cell pain, chronic pain syndromes, post-amputation, quite a number of amputees around here, particularly post-operative pain. Many of the patients here don't have the language for pain. They would rather keep quiet. And when you are trying to find out what their comments are about their views about the surgery, they don't want to say much. It's a different experience from what we find in Nigeria. And I must say that the drugs too are not here. The strong opioids are not available most times. And the NSAIDs, people don't keep to doses of drugs. And there are barriers, a lot of barriers from the practitioners. Also, the drug availability is a big barrier here. The techniques are not well known, so that's also one other barrier. Practitioners too don't work. So it's exciting. When I see what we do in Nigeria, I'm always excited and impressed. And I think the fact that many more anesthetists are getting interested in pain management means a lot more that our patients are going to be getting better treatment. I congratulate the Nigerian Society of Anaesthetists for allowing us to give this talk this afternoon. I'm sure so many questions have come up and Dr. Adetoye has done justice to them. Thank you very much for the opportunity.
Professor Falafakole. I must thank you once again, Dr. Adetoye, and you are the chairman of NMA in Osun State, and you have graciously volunteered to support NSA despite your busy schedule. And by this, I want to plead with every one of us here present that please keep supporting us because we are all NSA members. And this is the only way we can support ourselves. So on that note, I want to say thank you. Please don't forget to keep paying your dues. It's an experience we are seeing now that it's only when you want something from NSA, like a letter of introduction, and we find we have to tell you, please pay your dues. No, it doesn't have to be that. It doesn't have to be that because you want something from us. So we want to plead with you, please honor our requests, our humble requests, because money is the engine that runs the engine of the association. So thank you, every one of you, and I must say you have all done well by being part of this show this evening. To the education committee headed by Dr. Dati, I must say thank you so much to you and all your team members. So I'll be asking the PRO now to give some quick announcements. We shall be having an OGM very soon. Please hold on for him to make all these announcements, because we need you also to be part of this OGM so that you can talk to us, you can tell us what areas you want us to adjust in our service to you, because we want to be the best that we can in serving you. Thank you. Dr. Oshele, please.
Sorry, Madam President. I think Professor Leve is around. Can we allow
our Mama
her to say
has
something for 2
yes.
minutes?
Yes.
Prof, if you are around
yes.
and you wish to say something, please unmute and advise us as always. Thank you.
Welcome, Professor.
I'm trying to unmute. Hello, can you hear me? Hello?
Yes, we can hear you.
Good evening, everyone.
We can hear you,
Good evening, everyone. I'm sorry I joined a bit late. And it's a very interesting topic. What I could see in most of the presentation or discussion, we talk about the ideal drugs and how they are unavailable to us. I want us to drop some statistics in terms of our practice on what actually can work for us. Combination drugs that are available, collect and get the information across. So I think we need some research to bring up and how effective. I mean, it cannot be ideal. It cannot. We cannot continue to say opiate is not available, opiate is not available. But what is available, can we do some combination of management and see how we can move that management of pain forward, even despite our limitations. This is my contribution. I would love to see that come up in some papers and so on. Okay. Thank you very much.
Thank you very much, Ma. We have taken note of that and we'll work towards it together with SS. Thank you for that valuable suggestion. We are grateful to you as always.
My pleasure.
PRO, please, Dr. Shelley.
Good evening, the President, and good evening, my trainers and professors. Thank you for joining us again after our little break. The NSA OGM will be coming up on the last Saturday of the month of July 2023. That is 29th of July 2023. And the 31st NSA Annual Scientific Conference and AGM will be coming up in Gombe on the 27th of November to 1st December 2023. We also want to inform you that the 18th World Congress of Anesthesiologists will be coming up in Singapore on the 3rd to 7th of March 2024, while the 9th All African Anesthesia Congress will be coming up in Sultan Convention Center in Johannesburg from 16th to 19th September 2024. Please, like the President has said, we want to thank everyone that have paid their dues this year, and also to enjoy with those who are yet to pay, to kindly pay their dues. I will be announcing on our various platforms. Thank you.
Thank you very much, Dr. Shelley. On that note, all of you, and have a wonderful